COVID-19 daily live show with Doc Griggs and Dr. Derry. That's Doc Griggs, as you can tell. The handsome one over there. I'm Dr. Derry. I'm the struggling one over here.
You see that? He's stuck on behind the corner of this. Yeah, I don't know if you can see.
I can see myself. Did you text me? Apparently we're having some difficulties. Let's see what we got here. Oh yeah, I don't know. Let's see what Graham is. What is Graham saying?
It looks fine on Facebook, apparently.
Okay. All right. Cool. Well, how are you? You had a nice weekend. We had the weekend off.
I'm good. It was an interesting weekend. Watching people not social distance is always fun.
Yeah, that's rough, isn't it?
Yeah. Well,
I had a hard time. I had a hard time trying to figure that out and what people were doing. What was that? What did you see?
I just saw the pictures of people at the beach, not social distancing. You saw crowded areas. There are a lot of people that just refuse to. They won't accept it, and that's fine. It's okay. But the science is going to be the science.
Yeah, you're right about that. I mean, they're going to be accepting this thing really quickly once they start. And we'll go over the numbers in just a minute. But cases are looking great. Cases appear to be going down, and not only cases going down, but we're also seeing decline in mortality both globally and in the U.S. And so, which is of course a good sign. And I hope that we can continue to see this. But I'm not sure what's going to happen once we get all the all these numbers tallied up with kind of what you saw over the weekend.
Very appropriate. If I can just interject here, it's in the latest. It just came. You just got the same email I did. World Health Organization is warning countries could face a second peak in COVID cases even before we enter a second wave, which could result in a rapid acceleration in emergence case of clusters. Former Food and Drug Administration Commissioner Scott Gottlieb linked the increase in COVID hospitalizations to states lifting restrictions. I'm concerned that there are people who think that this is an all clear, and I'll just leave that to set the tone and let you take it away.
All right. There are a bunch of folks signing on. Thank you for everybody that's signing on. Mishan, Shanitra, Phyllis, thank you guys. And I can assure you, we appreciate Jackie. Thank you guys so much. We're getting lots of really positive feedback here, Doc Griggs. So a lot of folks are appreciating the work that we do this on.
I say KOA is in the building. I think Shanitra will know what that means.
All right, KOA is in the building. That's typically potassium hydroxide. I'm assuming that's not what Dr. Griggs
means. A lot more than that. The crew of Athena.
Is this when you were they had you queen for the you were
yeah, easy now, Tiger. Watch it. You've already pushed it with the huckabuck. Easy now. Easy. Why don't you talk what you know? This is epidemiology, infectious disease, and everybody will play nice. The tide turned, but believe me, they do. Clusters form. All right. What do we got, man? To be honest, a lot of people, seriously, it was a needed break to be able to come out for phase one, and a lot of people took way too much advantage of it, I think, and they just took it to the extreme. There are interviews there were people they don't understand how serious the disease is. You've seen this before, and let's get to the heart of it. Not to put a somber tone on everything, but just to get people back to kind of reality a little bit.
Got it. And Hail Athena is what was responded to. And,
yes, it was.
And I do appreciate we're getting feedback, positive feedback. Thank you, Jackie, on our sense of humor. So it's good that in this intense,
we're all family.
In this intense situation, it's good that we can continue to keep our sense of humor. So if you guys have questions, please, as always, this is a live Q&A session. I'm going to start and do about 10 to 15 minutes quick review on the where we stand in terms of the epidemiology of the pandemic, both on a global level, a U.S. level, then focus on Louisiana, then Orleans Parish. And then we got about 4 or 5 kind of interesting studies / articles that I thought would be fun for us to talk about and ruminate over. So we got lots of material. We don't have a guest on today, so today's show may be pretty quick. So let's just see where it all takes us. Doc Griggs, and also let's just say, please consider subscribing to our podcast. We do have a daily podcast called NoiseFilter. You can find it on all the podcast subscription platforms. Please,
Spotify, iTunes, you name it, we're there.
Google, all that stuff. Please leave us reviews and any sort of a ranking or rates that helps other people see the podcast. Also, we have a great website that you should go visit, and you can ask questions there too, which is NoiseFilterShow.com. So with that, you ready to go?
Locked and loaded. Let's roll.
All right, let us do this. And when we do this, unfortunately, Doc Griggs is not going to be heard. But you can see this as we get started here. I think there are a couple things for us to recognize. In terms of our global epidemiology, we're about up to about 5.6 million cases, rapidly going up to 5.7, 350,288 deaths. Overnight, we added about 64,000 cases. That's a little less than usual. That's good. And the number of deaths are 2,675. As we always say, every death is terrible, so I don't want to normalize this, but this number of deaths is going down. We're at about 2 people die per minute, which is, again, still crazy to even think about that. But you could see the cases, even though the ones that we're talking about has gone down just a little bit, but overall, you are just seeing this kind of slow trend upwards for a number of cases, but you are seeing really like a really nice curve downward in terms of mortality. And I think this really does reflect that we are getting better and better with being able to treat this disease. And being able to, thank you, Doc Griggs, being able to treat this disease. When you look at the U.S. Epi counts, you can see we're about 1.7 million total cases. We crossed that 100,000 threshold that we were so concerned about. You can see the number of new cases overnight was about 13,000. That's a little bit lower than usual. New deaths, 577, which works out to about 1 death every 2 minutes. So again, this is also lower than usual. The U.S. makes up at this point 30% of all global cases and 30% of all global deaths. And again, the U.S. Overall population, we are at about 4 to 5%. That's 4 or 5, let's just say 5% of the total global population is the U.S., is the population of the U.S. of 330 million people. But we make up 30% of cases as well as deaths. So we are significantly and disproportionately represented. Again, we've blown past these numbers here for Vietnam and Korean War. These are the mortality rates suffered at the hands of that military people experience, the U.S. military men and women experience, and we're rapidly approaching the levels of World War I. So we're going to very soon are going to be approaching the level of cases of people rather that have died in various wars. So here, the U.S., you are seeing this trend downward, and that's what I was referring to at the top of the show. We are seeing this trend downward, which is very good, and you could see that our mortality rates are really going down. And look at this. This is some of the lowest mortality rates that we've ever seen in the last couple of days. And I guess, that again speaks to, I think that we're just, as we are learning more and more about this disease process, we are getting better with it. Before I continue on and start talking about testing, I just wanted to see if Doc Griggs had anything he wanted to add to any of that at this point.
Yeah, I am. Again, I'm optimistic, but I'm very real about the situation. The numbers are going down, but we just had, I will say, based on what I've seen, almost a disastrous weekend in the sense that people still don't get it. The virus has not changed. The virus is not spreading the virus. People are spreading the virus, and the numbers that we're looking at are we're still living in war-like numbers. It's not natural to have clusters and spikes, and us to have a mortality rate that doubles every 5 days, and to live like that. We're losing members of our community. I know of several people at this present moment whose parents are on a ventilator, and some might be at end of life. So this is nowhere near over. It's not time to relax. In my home state of North Carolina, the numbers are starting to peak. We can't get comfortable. Nothing has changed. And I'm not Dr. Doom and Gloom, but I want to be a realist so people understand that if our behaviors change, just like this data that Dr. Derry we go over every day, and Dr. Derry explains, let us out and allowed us to experience phases of reopening, the data will put us back in the house. Just saying, just saying.
Yeah. That's a very, very good point. And of course I wanted some of that input, and somebody did send us a text here. But they're saying that today there's about 70% of people that were noted in the French Quarter were masked. And so of course that is encouraging. I actually have something I want to share with you, Doc Griggs, about an idea when I come in. We'll definitely kind of chat about that, as I think I have a great idea for something for us to work on, having to do with masks. But let's just quickly go back to the
So
hang on, there we go. All right. So this is looking at testing, and you could see again, some of the one of the best folks that do the best testing is Iceland, and they're about 173,000 tests per million. You could see the U.S. We're about 46, so we're at 1/4 of what some of the best countries are doing. Even though we do have the highest number of tests being delivered, that's largely because the outbreak is so significant here in the U.S. When you look at the total number of positives and divide it by the total number of tests, you want this number to be below 5%. We're at about 11%, which still implies that we're still testing higher risk, or people who are at a higher probability of being positive. Here in Louisiana, we're almost at 38,000 cases, with 2,701 deaths. You could see overnight we added 259 cases, and we added about 11 deaths as well, with Jefferson and Orleans obviously leading the pack with respect to number of cases, and unfortunately with the number of mortality as well. In terms of Louisiana's cases, it's hard to get a sense of this line. I don't know if it's, I can't predict. Every time I predict it's going up, it kind of dips down. So maybe this is just a straight line over a long period of time. Certainly this uptick in cases here is a concern, and hopefully this is just an outlier and definitely not a trend. When we look at mortality rates, again, like everything else, we're just seeing these really nice and satisfying decline in mortality rates. So that's really, really nice. When we look at case rates, we are 1, 2, 3, 4, 5, 6, 7, 8. Now we're still 9th in the country for cases at 8,189 cases per million people. So we still have some work to do with respect to really driving that case rate down. Looking at the mortality rate, here's our mortality rate. We're at 1, 2, 3, 4, 5, 6, 7. We're 7th in the country of mortality, with 581 deaths per 1 million people. And when you look at our testing, so Louisiana's testing, we've done a total test of 333,000, but that rate is 71,678 per million, and this puts us at 1, 2, 3, 4, 5, 6, 7th in the country. And I know that we can do better. Here's a couple of new interesting slides looking for the state of Louisiana. Look at that. Our infection rate is about 1.04. So that means that our R naught is not good. That means that we're going to start seeing an increase in cases. And that probably reflects that uptick that we looked about a minute ago. Our positive test rate is about 5.1%. Like we said, we like that to be under 5%, but I think that's still pretty good. We have plenty of ICU beds available, and the contact tracing has only been about 16%, and you can see here insufficient tracing to stop the spread. And you can see right now the hotspots for the state are really quite in the middle inland part of the state of Louisiana. So there's some couple of interesting statistics. Our infectivity rate here in Orleans Parish remains about 0.87, but you can see that the error bar around it is quite wide. So we may be dipping into 1.2 or maybe not. It's hard to say. When you look at the number of, this is the Orleans Parish dashboard, you can see that the number of new cases have been kind of jumping up and down for the state, but we're in orange. That's remained stable. Number of new deaths have remained stable. The number of new tests have remained stable in Orleans Parish, but you can see have been increasing for the state particularly. And again, as we look at ventilator use, we have plenty of ventilators. About half the ICU beds in Orleans Parish are used, and hospital beds are about 2/3 of them are hospital beds. And lastly, just want to highlight that the cases in Brazil continue to go up, although you can see there's been a slight decline in cases. Hopefully that's a new trend, and you can see mortality is continuing to go up. So with that, I'm going to stop here, go back to Doc Griggs, and see any thoughts on your part there.
So every day, I'd like this for this to be an education for our viewers as well. You mentioned the R naught. If you can explain what R naught is, I want to always give the daily reminder that each of the numbers you see here in the death column are real people with real families. The reason that we're following Brazil, Doc, is as people see them in the news. We've been talking about them for a while because they're in a different season than we are. They have not taken it as seriously for a number of reasons. I won't say they haven't taken it as seriously. Let's just say that they haven't been able to practice the social distancing and potentially had access to social distancing and some of the measures that we've had. And as a consequence, you're seeing their numbers spike. The reason this is significant is because they're in the southern hemisphere of the world, so the seasons are flipped. So you're seeing what could potentially happen as our second wave or our second peak in the first wave if we don't really respect the social distancing and what it takes to slow this thing down until we have a vaccine or cure. Doc, you make some excellent points. When we talk about we have plenty of ICUs and we have beds and we have plenty of hospital room, that's not good. If we don't continue to respect the virus and the power that it can yield in our bodies, we talked to a friend today collectively earlier today, and we talked about an experience that they had being a survivor of the virus and how their body is changed forever, at least for this foreseeable future, based on the results of the fallout of surviving the virus. So this virus is no joke. It's not the flu. Anything that you've had, any flu that you've had and not gone to the hospital is a mild case. 80% of the people that are infected with the virus will be asymptomatic, which means they'll have no symptoms, or they will be a mild case if they don't go to the hospital. Should they need to go to the hospital for whatever reason, usually it's for a shortness of breath. Their O2 sat, that pulse ox things that we tell you to wear that monitors the oxygen in your blood, their O2 sats go down to the point where they can't breathe. Without becoming labored, they end up in the hospital. That becomes a moderate case, and that's about 15% of the people, and they stay in the hospital. Now, for the other 5, that hospitalization progresses to needing a ventilator in order to using a machine to help them actually breathe. And sadly, only 12 to 20%, 1 to 2 people out of 10 actually come off that ventilator. So this virus, and then after, should you survive all of this, there's a recovery period that could last anywhere from 6 months to a year with trying to get something close to the baseline before you were infected. So this virus is not your normal flu. It's not your normal pneumonia. It's nothing that we've ever seen before. Thus, we call it novel. Doc?
Correct. There's the idea of we talked about this earlier today about how after people had Ebola, we saw these post-Ebola residual effects as well, and this is really a post-inflammatory process in which happens that your immune system gets completely hyped up, gets jacked up as a result of being stimulated by the virus.
That's a medical term, jacked up, y'all. Y'all got that, right?
In particular, from coronavirus, but we see it with influenza and we see it with Ebola or any of these other issues as well. We certainly see it with HIV as well. I mean, this is why people are so profoundly thin with HIV, is that's their inflammatory system just jacked up, revved up, and revving and revving and revving, and it's just stealing calories away. And so this is why you see people who are particularly thin or emaciated. Same thing with cancer. It's the same thing. This is why people get super thin that way. It's because their immune system is just functioning very highly. So, what Doc Griggs was talking about is that we were talking to a colleague today and who had a particular difficult case of COVID-19, and listening to their story and listening to them explain the fatigue that they still continue to have, listen to some of the other complications that they are continuing to have as well. And I think those stories are important. I think that those stories should be told so that people recognize it. There was a really interesting article that came out this weekend, and I think I shared it with you. I can't remember if I shared it with you or not, Dr. Griggs. And this is me not trying to be political at all, but this is just the story. What it showed was that in states that Trump won in 2016, they experienced significantly more economic hardship, but experienced far less COVID hardship, right? So they lost more jobs, but they had far less cases of COVID. And in states that Hillary Clinton won, you had far less COVID financial hardships, but you had significantly higher levels of COVID, which is a really, really interesting study to think about. And so this is why you get a lot of these protesters that are out there protesting in states that Trump won, was largely because these are folks that experienced more financial pain, but didn't really know anybody that had COVID-19. In fact, there was another article that came out this weekend that showed, did you see this, Dr. Griggs, that 75% of Black and brown people in the country have experienced somebody or know somebody who have experienced COVID-19, as opposed to non-communities of color, so white individuals in particular. And they didn't give a statistic with that, but that just it's significantly higher. Do you know what the number is for white folks who've experienced it? I think
no, but what the article I did see in the Guardian was that the rate of infection was 3 or 4 to 1 for African Americans and other groups and white Americans. Right. So it's very serious. And I need people to understand that it's not a genetic predisposition. It's not because you're Black or African American that you're contracting COVID. This is just the study, and it has a lot to do with health disparities. It has a lot to do with history. It has a lot to do with a lot of things that existed way before COVID came into being. Matter of fact, when we were talking to our colleague, to be quite honest, she was not going to the hospital until Dr. Derry actually pushed. So it's a number of things, but the thing is, if you know that the target is on your back or on your front, you know what you have to do to protect yourself. We need to work together to try to get our comorbid conditions. We need to increase our dialogue. We need to increase access to care. We need to, if you start talking about the number of people and the ratios of the frontline workers by race, and the lower socioeconomic classes. I mean, there's a lot of factors involved, but it needs to be a conversation that needs to be, while the Band-Aid is off the wound for health disparities now, but ripped off by COVID, we need to start having these honest conversations now about how to fix things, because what we do for the least of any of us, we do for everyone. And I don't care what your definition of least and what lens you're looking through. I don't mean money. I don't mean access. I mean health disparities. If we're going to have equitable healthcare, we need to have equitable healthcare, and we need to understand this virus isn't discriminating. It's just looking. All the virus is doing, and to put on an ID hat for a minute, this virus is walking around just trying to get into our human species any way that it possibly can, and it doesn't want to kill us off because it's no selective advantage for it to do so. Meaning that if the virus kills the host, it can't pass on its genes, and that's what it wants to do. Doc, we got a question over here real quick. I think that you'd be real interested to answer, and it was an article that I read yesterday, and it kind of, yeah, I'll just read it. It's from Lynette. She says, how is the hospital firing of nurses and nursing and support staff impacted the overall COVID-19 now?
Well, I mean, that's a very good question. I have some questions that are lined up here too, by the way. And please, we enjoy answering your questions. We will be here, and we'll stay until every last question is actually answered. I don't know. I haven't seen per se exactly how much the firings of nurses and support staff, how that has had an effect at this point. I think that it's still a little too early to see, and I think that it's going to take a little bit of time for us to be able to determine that for 100% sure.
So interestingly, I read an article today. I can't remember whether it was NPR, it was a Guardian, or one of the two, and it talked about some of the nurses, some of the same people that were on the front lines to fight this virus in areas where the clusters first broke out are now being laid off because the hospitals have slowed to the point with non-COVID conditions. Social distancing, this way, next care system is going to get overwhelmed again.
Yeah, no, you're 100% correct. There was I was quoted in Vice. Eric, is everything okay?
Yeah, I don't know. We're good. Just keep talking. You just keep going.
All right. I was quoted in Vice as well not too long ago. About a story about exactly that, and the idea of why we are seeing some of these increases, in firings. And to me, it doesn't make any sense whatsoever. Why are we? One, this is a healthcare system for profit. So let's just talk about that. And hospitals, if they're not making enough money, and if they are not making the profits, or if they're not making bottom lines, they just have to cut. And I just think that is such an unfair system because one of the reasons we are in the position that we're in right now is that we did not invest in public health infrastructure. We did not have a very strong primary care healthcare system just here in the US. And certainly this is largely because, again, we do things by profits. And if we're not making money, or if we're at least not able to cover the bottom line, then of course what happens is that the people lose their jobs. Whereas what these jobs should have is some sort of governmental or federal protection attached to them. So this way hospitals are not having to struggle to try to make money to remain open at any one time. So I hope that we will see at some point some relief for some of these folks, and I hope that the fact that they lost jobs is not going to act against us at some point in the future. Shanitra asked, what attributes for the decrease in mortality, and is a plan of care changing, or are there new medications? And I think that's a great question. Let me bring in Doc Griggs. Doc Griggs, people want to know about medications, why the mortality is going down. Are you there? Your screen looks a little funny.
Yeah, the screen looks green over here, and that's fine because it matches access. Can you hear me?
Yeah, I can hear you.
So what was the question again?
Why is mortality going down? I got to plug my computer in, so can you answer this question real quickly? The video
Sure.
is sucking.
Why is mortality going down where specifically?
Just in the U.S. and around the globe.
The mortality is going down in certain areas. But if you look at a mortality rate, the more testing you do, the more asymptomatic people that you get, the lower the number will go. At first, because there was a scarcity of testing, we were testing people that were sick, and the sicker people will make the numbers seem higher. We're actually also getting better at treating the disease. As we get better at treating the disease, and we implement things like social distancing and keeping people away from each other, all numbers tend to go down. First, you see the number of cases go down, and then secondly, as we get better in treating and getting people out and less people, to be quite honest, the numbers for mortality go down. This is all a learning lesson for all of us in that this is the first time it popped on the scene. So everyone in the community learned about this virus at the same time that the scientists did. So we're getting a firsthand look at the scientific process. We can't attribute it right now, the decrease in mortality, to any particular drug. We can't attribute it to any vaccine. We can only attribute it to a change in our behavior, understanding and respecting the fact that what's worked in the past works now. It's evidence-based. It's staying away from each other. Social distancing and wearing a mask works. If you decrease the number of cases, your mortality rate will go down. Dot?
Yeah, it's a great question. I also want to add to it just very clearly that as we understand this disease process more, we are getting more comfortable with it, and this is why we are seeing these we're seeing these rates go down, which is a great thing. One of the folks here says, what advice would you give to a person who is a cancer survivor from 2017 that has asthma returning to work in New Orleans? I work with approximately 50 men recovering from addiction. I've been home since mid-March and thinking of returning to work on 6/1. Do you think I should wait until phase 2? It's very challenging working from home and really ready to go back. So this is somebody who essentially wants to go home, or wants to come back to work as a result of having stayed home, somebody who's at risk for cancer. So Robin, let me say this. The most important thing that you can do is make sure that you're wearing masks, everybody around you is wearing masks. You should not be going into a room at all with anybody who is not masked. If somebody is not masked, it's really, really, really inadvisable for you to be able to go to work and to work with those, because you never know who's pre-symptomatic or asymptomatic. So masks, far and away the most important thing to do. Now, of course, I'm going to tell people to wait as long as possible because that's super important, because that's going to significantly decrease the risk of transmission. But if you do need to get to work and go to work, or want to, or I understand that staying at home cooped up is not a place where you want to be. Of course, at that point, you really need to consider masking, not only yourself, but those around you. So, Doc Griggs, somebody with I don't know why your screen is green. somebody with asthma wanting to know what they can do.
Stay home. This is a respiratory disease, and it's going for people. The virus is targeting people with respiratory illnesses. You need to be as careful as possible. We would tell you that the advice is to avoid everyone as though they would be infectious. We know that you need only leave the house for essential trips. We know you need to mask. Know you need to be up on your medications and talk to your primary care provider and your pulmonologist if you have it. But right now is not a time to let your guard down. If you have asthma, make sure to take all of your medications.
Absolutely. The next question here is, how long can somebody be asymptomatic?
So interestingly, what we found is that there are some people that never experience symptoms. Typically, people present with symptoms. It takes 2 days, about 48 hours before people present, and Average is about you're in about what 2 to 14 days, 5 days. But some people may never develop symptoms, which is why contact tracing and testing. And when we say testing, we mean virus testing or PCR testing, nasal swab testing, not antibodies. I hate to even bring that word up right now. That's why testing is so important, because you have some people that never get symptoms and they end up shedding and spreading the disease to others. And each person has their own individual response to this virus. Some people can have an overreaction of their immune systems and be perfectly healthy and end up on a ventilator and sadly passing away. Doc?
Yeah, thank you so much. Shanitra has a question here of what are the changes in treatment? And I just want to be clear, it's not so much that there's changes in treatment, it's just that I think that we recognize at first it was kind of, we took basically a big, round block and tried to stick it in a square hole. And I think that as doctors became more experienced with the disease and were able to share, not everybody needs to be ventilated. Some folks that are hypoxic, that are the so-called happy hypoxics, don't need to be ventilated. There was a better idea of how to prevent secondary infections that you see in the hospitals and stuff like that. I think the other thing too is also getting people, we're testing more, we're able to get sicker people to the hospital sooner, we're able to treat them sooner. So it's not so much that changes in treatments have changed, it's not that there are so-called better treatments, it's just that at this point, I think we as a medical profession are getting better with how we're managing this as well. Christine McDaniel has a great question. I'll leave that one to you. It says, whoa, that's super psychedelic. That says, what are your thoughts on starting schools in fall? Doc Riggs, what are your thoughts about school starting in fall?
That's an interesting question. It looks like states are making plans to do so. There are CDC guidelines out about best practices. If people go to work, it looks like kids are going to have to go to school. That's one that needs to be determined. I'll just say that we do not have a vaccine. We do not have a treatment or cure. There are things that are going to be done to keep things from what I understand, they're talking about alternating schedules. There's blended and virtual learning ideas that are being pitched. So I think I don't really know, to be quite honest. We can only go by what the CDC recommends. And right now it's kind of up in the air.
And how about that article I sent you yesterday? Why don't you maybe refer to that too? I sent you that article to you and Dr. Hebert about ACE receptors being lowered in children's nasopharyngeal passageways.
Which is why children, so the ACE2 receptors are the ones that the virus is targeting. We talked about it this morning on Fox, that they're you find them, some in the eyes, some in the nasopharyngeal, and some in your lungs and stomach, which is where you see symptoms. It's saying children have less ACE2 inhibitors, that's angiotensin converting enzyme receptors, which could be why they get less sick. But that does not necessarily mean that they would be less infectious. So we just don't know, to be quite honest. And I'm going to warn that you need to be comfortable with those. All we can do is, as we try to phase in and reopen, is do the best that we possibly can and let the data allow us to come out. And if the data shows us that we have to go back in and be more restrictive, to do so in the safest way possible without endangering, especially our babies, but members of our community. Doc Lynette has a question, and she wants to know how can we, and this one is one that I think you will enjoy answering, how can we rely on rates in states that are not posting accurate info? It's a great question.
That's a great question. And we talked about that, I think, either yesterday or today in the podcast for NoiseFilter. And again, please subscribe to our podcast, NoiseFilter. You can find that on all the podcast subscription websites. So we can't, quite frankly. And the two states that I think that you may be referring to are Georgia and Florida. Doc Griggs and I have reported on this repeatedly, trying to understand why and what is going on in these states. And quite frankly, it's, I think that people are hiding data. I mean, I just, there's no other way of stating it. I can't imagine what other reason people would be flubbing their numbers the way that they are, but they are, and we can't trust it. This brings up another point, is that there has not been a centralized way to count a case. Usually the CDC is very specific about how they want cases to be counted, what you do. There's just been no guidance. And as a result of this, there has been an epic cluster. We just don't know what is going on. Everybody's speaking different languages. And when you see one of the reasons why we make up 5% of the total population on the globe, but we're 30% of cases in the U.S. is 30% of global cases and 30% of global mortality rates. These are the sorts of things. That that a non-centralized response will bring. More cases and more mortality, and you have states that are just basically able to flub numbers, and there's no question that that Florida was caught doing that just not too long ago. Doc Riggs?
Doc, can you talk about the numbers of deaths per minute right now?
Yeah, I mean the number of deaths per minute are in the U.S. Is I think it's here. Let me go to the chart. It's 1 for every 2 minutes. And I need to go to the charts. Hang on a second. Let me do it.
This is deaths per minute in the United States from COVID-19 right now.
There we go. So when we're looking at deaths per minute, here you can see in the state of Louisiana, the number of deaths per minute. I thought I had it here. I'm sorry. I did have it here, didn't I? I know that globally it's 1 death per 2 minutes in the U.S. And then looking at Louisiana particularly, which I apparently just kind of flew right by. Oh, right here. It's well, no, in the U.S. I'm sorry. In the U.S. it's about 1 per 2 minutes, and then when you look at globally, it's 2 people die per minute, which again is just super hard to kind of wrap our heads around when you think about something like that. Doc Riggs?
So in the 45 minutes that we've been on air, 90 people worldwide have died.
Yeah.
19 people, 22 people in the United States, and soon to be 23, have died in the United States from COVID-19.
Yeah. Yeah.
This is not a time to get comfortable. It's a time to celebrate because we're here, but remain physically distant and socially connected. Of course, wash our hands. And while you're at it, brush your teeth. Since you're going to be keeping your breath to yourself, make sure you brush your teeth and protect each other. Remember, you're wearing a mask to protect those around you, and they're wearing their mask to protect you, the cloth mask. Doc, you want to talk about the significance of the cloth mask? Because you were saying mask for everyone weeks, almost a month or more so before we got here.
Yeah, masks for everyone are incredibly important. You protect everyone else around you from your own virus. As Dr. Briggs likes to say, keep your virus to yourself. That is so important. There was a question here about daycares being safe or not. What are your thoughts about daycares?
Daycares are something, again, it's like the schools that we're going to have to discuss. It's going to have to take a lot of deep, hard thought on how to safely do that and to really make sure the kids are social distance. Like, it's just there's no quick and easy answer to any of that. That's my honest thought. Yeah. That's not a bridge. That's just an honest thought. It needs to be spoken, and it drives you crazy. But I'm gonna say, hey, Uncle Leroy, while I'm at it.
Here are a couple of some good stories here, Doc Riggs. I know that it's hard to read. It says here, asymptomatic infections in COVID-19 revisited. Asymptomatic persons infected with COVID-19 can transmit disease and likely count up for half, but no less than a fifth of all infected. So now they're up to 50%, something that I've been saying for a long time. but an uncertain proportion of new infections and policies and programs to control the pandemic should be made with this sizable portion in mind. That's an amazing number. Dr. Griggs, what are your thoughts about that?
That's exactly what we were just talking about, is people walking around and not knowing that they're infectious, which is why when you see scenes like bars and beaches and parties, that's really people not wearing masks or socially distancing. It is, I'll just say, it's socially irresponsible, not looking out for the people around you, because you could be hurting the people that you love and not knowing it. So we want to be careful until we can get data to keep us out and be safe.
Absolutely. Absolutely. So let's go to the next story here. Here, something that you were on top of right from the get-go. You really smelled this one out, I would say. You sniffed this story out right away, which is anosmia, of course, and that means difficulty smelling. But we don't know what the true incidence and mechanism of anosmia is. We don't understand what actually may be causing it, but I think it is probably understood at this point to be 100% related to COVID at this point, and is considered definitely one of the major symptoms that people look for. Any thoughts there, Dr. Griggs?
Oh, there was just a bunch of people that, and it just so happened, just to show you the nature of the virus, the anosmia, or the inability to smell, the change in taste and the inability to smell. If there are a lot of you out there that couldn't smell, it might have been COVID-19. We're not really sure. But the thing is, this virus is doing whatever it can to mask itself to get into our genome and stay here for a while. It's interesting, which is why we have to monitor this virus so carefully and record all new symptoms. It's not that we're changing and we don't know we kind of don't know what's going on, but we're learning. At first we thought it was just fever, shortness of breath, and dry cough. And then as of late, we've noticed that fever is being reported less and less as a presenting symptom. So
absolutely.
We can't sniff out the fevers, right?
But you were quick to sniff it out, though. I will say that. It's very impressive. So look at this story here. So SARS-CoV-2 infection protects against rechallenge in rhesus monkeys. So that's a really good story. So this is another story using monkeys that shows that when animals were challenged with a virus again, that they were not reinfected. So I'm thinking, I'm starting to move into the idea of that once infected, and I'm going to answer Dave Roston's question as I explain this. Once infected, I think you're probably immune, at least to this iteration of the virus, for some time. How long that immunity lasts, what happens if the virus becomes endemic within the population and starts to circulate, and what if there's a new virus next year that is somewhat changed or resistant? I don't know. And Dave Roston's question is, if somebody tests positive for antibodies, can they assume that they're immune? To a certain degree, yes, but we don't know what that immunity is that they're looking at. That immunity could also essentially be reflecting, coronavirus from previous experiences. Remember, the coronavirus is a common cold virus, right? So it can essentially the antibodies that you are detecting are essentially picking up on previous viral exposures that you may have had. We assume that the antibodies and the antibody testing are picking up on the SARS-CoV-2 virus. We don't know. There has been no antibody test that has been approved by the FDA. So it's a very, very important thing to consider. But we think that the positive coronavirus antibody tests ideally are positive for SARS-CoV-2, but at this point, there's no way for us to know whether or not that they may be cross-reacting with other viruses as well. And I think that's really important for us to recognize that. Dr. Griggs?
Breaking from CNN just across the wire. The CDC has just come out to say that the antibody, Center for U.S. Disease Control and Prevention said in new guidance that the antibody tests that might be used might be wrong up to half the time. Antibody tests called serologic tests, evidence of human response to infections. Antibodies in some persons can be detected within the first week of illness onset. They're not accurate enough to use to make important policy decisions, the CDC said. Serologic tests should not be used to make decisions about grouping persons residing in or being admitted to congregate settings, such as schools, dormitories, or correctional facilities. Serologic tests should not be used to make decisions about persons returning to the workplace. There you have it. There it is. The antibody tests, we don't know enough about them. I wanted to go back when you were saying, we were talking about rhesus monkeys. I do have experience doing research with animals. First of all, if we go back to what happens in one animal does not necessarily translate into what happens in another. So this virus could have had an antibody response that was appropriate in rhesus monkey for decades, years. Who knows? We don't know what happens when we cross the species divide. What Doc is saying, what they do know is there's some type of mounted IgG or antibody response, but we don't know how long it lasts. And the fact that we're only 7 months in to knowing really seriously about this virus, the best answer we can tell you is we don't know, but the CDC said do not use an antibody test to determine anyone's immunity to congregate or to go back to work. And that's hot off the press.
Thank you so much. I appreciate it. You know, the best part of that segment that you just did there, Doc Riggs, was your impersonation of a telefax noise.
But you're not going to, we won't discount that information. This is straight up from the CDC, because how many times are people asking you about getting an antibody test and trying to use it as an excuse to do something that we're not going to sign off on because we just don't know.
Yeah, how many times does that happen to you? How many times have you heard it?
Oh, too many times. And then what happens is, and I'll tell you, if I'm wrong, folks, let me know, but it gets confusing. They call it serologic testing, antibody testing, virus testing, nose swab, PCR, antigen. And then we say we want to just do testing, and you don't know what you're signing up to get tested for. So the testing that we need to worry about is viral testing, virus testing, PCR testing, nasal swab testing. Let's worry about that. They're working on another method of doing so, and that's called antigen testing. But all of that is still testing for presence or absence of virus. Either you're positive or you're negative, and that's what we're worried about doing on a large scale so we can protect members of our community.
Absolutely. How do you like my breaking news?
I love it. Now do that without the music.
Here we got one last story. Here somebody says mind exploding. I was hanging the hope the antibody test was going to be my papers back out into the world. No. And I've been telling and I've been trying to explain to people, everybody hung their hats on testing, man. I wish, and I was testing. I don't even know what to say. I wish that testing would have been the end all to be all. I really do. I wish that antibody testing was going to give that hope, but it's not. You know what's going to give hope? Is if for 30 days, everybody wore masks or some sort of face covering when they went outside. If we can get the whole globe to do this, wear masks for 30 days or wear some sort of face covering, that would be our ticket. If we did that 30 days ago, if we did that, we would be done now, right? If at the end of April we were like, well, everybody should just wear masks for 30 days, we'd be done with this business. But unfortunately, that's not the case. Please watch out for my op-ed. We are submitting it tonight to various newspapers. Hopefully, we will get lucky with that. Dr. Riggs, there's a couple more questions here that I wanted to kind of address really quickly. And that is, do you recommend everybody get tested if they have access at this point, even if they don't have symptoms? That's a really good question, Carrie. I would not get tested if you don't have symptoms, period. Now, if you're at a job that requires you to be tested, if you need to get tested for one reason or another, of course, then please go ahead and do that. But if you're asymptomatic at this point, the thing with testing that we have to consider is that we have to do smart testing. So we have to do smart testing. So that's doing the right test at the right time to the right people. And so right now, if you're in a cluster of cases, or if you've been identified through contact tracing that, and even though you're not feeling sick, but somebody says, hey, you were at you were at a restaurant, and at the same time that somebody tested positive 3 days later, you've been contact traced, and we want you to go and get tested. Yes. And so that's what's referred to as smart testing. So this would be getting the right test at the right time, again, to the right people. So, but if you just are wondering, should I just go and get a test right now? No, because the test that they're testing you for is for the virus. And if you're not feeling symptomatic, could you be an asymptomatic carrier? Sure, you could be. But the likelihood of you catching it right at the right time when the virus is there, it's not likely to be the case. Dr. We got to start wrapping up here in a minute. I just want
got a question over here from Deborah. She wants to know about, does blood clotting have anything to do with COVID-19? It actually does. This virus attacks our blood vessels, and it's attacking our cardiovascular system. And there has been an increase in the incidence.
Embolic events.
But the propensity for blood to clot. It's part of the inflammatory response and part of the damage that's being done. Those clots cause damage as they go throughout the body, as they would even without COVID. But COVID is increasing the propensity or the likelihood of clots. So absolutely, that's been something that's newly described. Again, we are all studying this from a lot of these angles, so it's excellent to report, and I'm glad that you brought that point up, Deborah. Doc?
Absolutely. One last quick story that I think is really important for us to review, and that is we are seeing a huge decline in vaccinations in children. Here, this says decline in child vaccination coverage during COVID-19 pandemic. So I know I sent you a graph yesterday, Dr. Griggs, showing the amazing decline in measles vaccinations. So if you have children, if they skipped out on their vaccines, if you have nieces or nephews, or if you know people who have children, please, please, please make sure that everybody gets caught up with their vaccines. Dr. Griggs, I'll give you the last words. We have another minute or two.
No, I just want everyone to be safe. Just stay home as much as you can. Use common sense. Wear your mask, wear your mask, wear your mask. Wash your hands. Be physically distant and socially connected, because what we're trying to avoid as well is a mental health pandemic. You're not alone. We're all in this together. Get checked, get fit, get moving. Y'all can't see me. Get checked, get fit, get moving, breathe, check, step back, and here's 2-finger peace.
There's 2 peace. Thank you, Dr. Riggs. We're getting a lot of love here, so we love all of you. Thank you guys so much. Please wear face masks. Please stay at home. Please wash your hands. And please, please, please.